So I would like to request our next presenter, who is Dr. Rafiq Ahmed, who is a very renowned electrophysiologist joining us from USA, and he is going to talk on device therapy in heart failure. So I would like to request Rafiq Ahmed, sir, to share his slide for the presentation. Sir, you can share your slide now.
Good morning. Actually, in Bangladesh, it's evening. Thank you for inviting me. Let me see. I think I'm having a little problem with this. Okay. You can you see my slide? Hello?
Not yet, sir.
Not yet, not yet.
My side is saying I'm sharing.
You can see from here.
Okay. We can
Can
see
you
your
try it?
screen, sir, but not the presentation.
I'm going to restart it again.
I think rejoin. Yeah, restart. Yes.
Can you hear it now? Can you see it now?
Yes.
Yes.
Yes,
Now
sir.
we can see. Yes. Now we can see.
Thank you, sir.
Yes, sir, we can see.
Okay.
Yeah, we can see, and if we can hear you clearly, you can proceed now.
Okay, great.
Oh,
So,
fantastic, sir.
I think this is a wonderful series of lectures. One of the things that I like to emphasize that, yes, we have device therapy, but first of all, thank you for inviting me. I'm going to make it brief. Most of it is old information for device therapy, but one of the important things for the audience is the heart failure treatment. I think the previous two lectures, Dr. Firajullah and Dr. Moro made a wonderful presentation. The device therapy comes very last. Medical treatment is the most important thing in heart failure. And it starts at a very early level. So what is heart failure? When, just for basic definition, when the heart cannot meet the demand of the body. That's what it is. A very old definition, but congestive heart failure is that plus volume overload. This is the combination. So we must have volume overload to call it congestive heart failure. And I always show this slide that there is a donkey which was healthy at one time and carrying this 9 sacks of grain, and it can't do it anymore. And how to make this donkey do the job plus make him feel better. That's the treatment of heart failure. In America, there are 5 million heart failure cases. In Bangladesh, it should be at least 2.5 million because the population of Bangladesh is half of United States, and it has significant economic impact on the nation as a whole. So I'm going to skip through this. This is just a recollection for the young physicians, not for the old. We have New York Heart class 1. I always remember class 1 means there is no physical limitation. And then class 4 will be somebody who is sitting down and is short of breath and symptomatic. And in between, these are class 2 and 3. How do I define class 2? I always ask my patients that if they can go up 1 flight of stairs, it's a simple thing, and then continue walking, they're probably class 2 with shortness of breath. But if they have to stop in the stairs or in the middle of the stairs, or they have to stop at the end of the stairs, that's class 2. This is important. In my history and physical, when we talk about heart failure clinic, we must remember this. It's not just giving medicine. How do I quantify these patients' symptom? So I always write down how far my patient could do, so that I have an objective evaluation of how to manage these patients. And of course, the newer classification is geared to prevention. That means if we identify patient as new class A, that means if I treat hypertension, if I treat coronary artery disease, they will not progress to heart failure. I think that is the key step for any country, not only Bangladesh, but even in the United States. This is a focus now that we have to treat this patient when they're in class A, identify them, treat them, and that will reduce significant economic burden on the nation and the patient themselves. So this is the cascade, that is the old cascade, which is basically there is myocardial insult, and this becomes a vicious cycle unless we stop this cycle. I'm not going to go over this, but previous speakers have touched on those. So what are the treatment goals? To relieve symptoms, reduce morbidity, and improve survival. These are the three keys, but the primary thing is to relieve symptoms. And for that, we have medical management. We define drugs, including some newer drugs that are wonderful. One of the things that is going on in heart failure treatment that we have better understanding of molecular level where the dysfunction is at a level of mitochondria, and newer drugs are being developed and have used. And I request that when you study medicine these days, you will have to go to the cellular level, understand cellular mechanism of the disease process, and how the newer drugs are going to come and work on these patients. So this is an important slide, because if you look at New York Heart Class 2, majority of the deaths are going to be sudden deaths. But as the heart failure progresses, as you can see, that the number of patients dying from pump failure increases. So as we reach the New York Heart Failure Class 4, 56% of patients will die of heart failure. And that is key important, that when we talk about device therapy, that we're going to get the maximum benefit in New York Heart Class, not Class 4. So that's why early identification and treatment of patients are very, very important. So this is a patient of ours who had a heart failure syncope in the old days. This is an old slide from 1994. Patient died wearing Holter monitor. Patient developed ventricular non-sustained VT, developed VT and VF, died. And this is what we are trying to prevent in heart failure patients. But if you look at the underlying arrhythmia of sudden death, if you remember that, look at it, 62% is VT, primary VF, and there is a significant portion that dies of bradycardia. And this group of patients, actually terminal heart failure patients, nothing can really help them. Normally pacemaker will not, they just become bradycardic and becomes refractory to treatment. So we knew for many, many years that the risk factor for sudden death was that EF less than 40% and frequent ventricular premature beat. And that's why there's an early focus on treating this ventricular arrhythmia with medication to reduce mortality. The problem was that there was no randomized study, and we'll come to this. And how can we treat these patients? We treat them empirically, Holter guided, EP guided. All this combination was used in the past, which is history now. And then non-pharmacological treatment of VTVF was catheter ablation, ICD, and transplant. So this is an ICD. So there are two things that we talk about. One is primary prevention. That means we do something to prevent an event that has not happened yet. And secondary prevention is the event has happened already, and we are trying to prevent a further event, secondary prevention. And the multiple studies that were done, you can go over this. There are studies drug comparing antiarrhythmic drug versus placebo in these patients with heart failure, conventional antiarrhythmic versus amiodarone, and then ICD versus antiarrhythmic drugs. These are the many drug studies. One landmark study is that this is important, CAST study. Physicians who have not read this study, I would recommend that they read this study. This study showed the importance of placebo in any trial. This study was designed to suppress arrhythmia in patients with cardiomyopathy or ventricular arrhythmia, and the best drug was flecainide. And the study started in 1987, was stopped in 1989. And what we found out that here is placebo, and this is flecainide and canide. Placebo actually saved lives. And that was a landmark study. That's why in any study that we do, there must be a placebo arm, because sometimes the medicine can be harmful. And then I'm going to skip through many years, and then this data that we had a thinking process that amiodarone is a wonder drug and it will save life. And multiple studies were done, and this is a well-designed study, CHF STAT study. What this study did is it took patients with CHF and then ejection fraction less than 40% and more than 10 ppc per hour, and they randomized them amiodarone versus placebo. If you look at this study, that amio versus placebo, there is no difference in mortality. So when we prescribe amiodarone for patients, please keep in mind that amiodarone has no impact in improving survival in patients with heart failure. And this is also applicable for sudden death. And so the question was, how do we improve the survival? There are multiple device trials that were done. I will not go over those studies, but this is the study that was a very important study, SCUD-HEFT, sudden cardiac death in heart failure. This study randomized patients to conventional treatment and placebo, conventional treatment with amiodarone, and conventional treatment with defibrillator. And the distribution was pretty good, 833 patients in each group, which was really remarkable to enroll such a large number of patients in this study. And what they found out that if we compare ICD versus placebo, this greenish line is the defibrillator arm, and this is a placebo arm. And you can see that at the end of 5 years, the mortality in defibrillator arm was less than the placebo arm. Please remember one thing, that even patients with ICD also died, like there are 182 deaths in this group. And the other part that's important, if you look at this study, there is no difference for the first 18 months, and then the device started splitting. So that means if I take a patient whose survival for some other reason is less than 1 year, and if I put a defibrillator in, then it's not going to help at all. And it can be somebody with cancer or somebody with very terminal heart failure, who I think is going to die within the next 12 months. I don't think there will be much benefit of using device in this patient. It is good for patients who are going to survive longer term. So who will be that patient? Let's say I have a patient who is 52-year-old, had a myocardial infarction, ejection fraction of 30%. And this patient otherwise is doing well. Those are the patients who are probably going to do well. And then if we add amiodarone on that, you can see that amiodarone was as good as placebo. That amiodarone has again proven that there is no role of amiodarone in treating patients with heart failure. But do we use amiodarone in this group of patients? Yes, we do that. If somebody has a defibrillator and getting recurrent defibrillator shock for some reason, and we want to improve the quality of life, we will add amiodarone to those patients. The other group that we use amiodarone would be a heart failure patient who is suffering from atrial fibrillation. And we want to control the disease, atrial fibrillation. Then amiodarone is a good drug. But please remember, amiodarone is a very toxic medicine. They should be carefully monitored. We cannot just give amiodarone and forget about that patient. So the question would be quality of life. Can we improve the quality of life in patients with class 3 and 4 heart failure? Yes, if patient has left bundle branch block, then the left side of the heart contracts later than the right septum, and it makes it an inefficient pump. And if we then pace on the lateral wall of the ventricle, then we can improve the contractility of this patient. And this is just, I don't think this is going to work. What we do, we put a lead on the right side of the heart, and then we put a lead on the left side of the heart and an atria. And if we do synchronized pacing, we can see that we make the QRS complex narrow. And there is study to show that this is a significant benefit in improving symptom. And an ideal scenario is this: there is a lead on the right side and the lead on the left side. So this is a study, that initial study that was done, that patients with biventricular pacing, their walking distance was more than people with CRT. Now, if you look at this, the patients without CRT could walk 300 meters in 6-minute walking test. With biventricular, they could walk 350 meters. Does it really matter? For us, for me, or for our audience, it doesn't really matter a difference of 50 meters. But in a patient with heart failure, it matters. That means they can go to the bathroom now, or they can do the normal daily activity. That is important. So that's why that the current guideline is that no question that pharmacological treatment is the mainstay in patients with heart failure. And patients with cardiomyopathy ejection fraction less than 35% should be considered for defibrillator implantation. And if they have left bundle branch block, they should be considered for biventricular pacing. Now, there are a few things very, very important. When somebody comes to us for treatment, when patients are referred for defibrillator implantation, first thing we do, we look at when the diagnosis was made. Have this patient been on maximally tolerated heart failure treatment for more than 3 months? And we follow this very, very strictly. That means if somebody is on heart failure treatment, that treatment should be maximized and they should be treated for 3 months. And then we reevaluate the ejection fraction and before you deciding on defibrillator, number one. And same with bundle biventricular defibrillator, 3 months of medical treatment, and we usually put it in left bundle branch block with that is, even though if you look at the literature, they will say any white QRS is good. We don't, in clinical practice, we do not do that. That was done as a blanket. I do not believe that patients with right bundle branch block will benefit from biventricular defibrillator implantation. They should have left bundle branch block. Sometimes we will take patients with sinus rhythm, marked first AP block, right bundle and left anterior fascicular block to put a device in. Now, there is a caveat. So who should put biventricular? We need a clinical experience. If somebody is doing 1 or 2 devices here and there, just because I can do pacemaker doesn't mean that I should be doing biventricular pacing. There is a significant expertise that is needed in this. Second, if the lead position of the LV lead is inferior, actually you are going to make the patient's symptom worse. So what we do, when we attempt biventricular defibrillator implantation, if our lead is not in the lateral wall, we abort the procedure. We say we could not do it, we're not going to do it. There is a new technology that is off-label use. And in context of Bangladesh, I think left bundle pacing is something that should be considered, and to develop expertise that we can go through the right ventricle and then find the his bundle and then go about a centimeter below the his bundle and use a lead, active lead to reach the left bundle. And we have patients who actually are doing very well with left bundle pacing. I think for Bangladesh, one of the technology that should be developed quickly is left bundle pacing. This is an off-level use, but I think it is still beneficial. Despite all this, one of the things that we have to remember in any country, that the cost of the device, more so in Bangladesh, because in Bangladesh, patients pay for these devices from their pocket. So please be careful when you choose either defibrillator or biventricular defibrillator. Who is the patient? Does this patient have money to afford medicine? If somebody gets a biventricular defibrillator and cannot afford medicine or not compliant enough to take medicine, I do not believe they should get device. And other important part, that etiology of heart failure first should be identified, treated, and the prevention. That means treatment of the class A group of patients is very, very important. We should, as a community, we should educate people to treat their hypertension, diabetes mellitus, and risk factor for coronary artery disease. I'm going to stop here. Thank you very much for your time and patience.
Audible?
Yeah.
Do you hear me? Thank you, sir, for your magnificent presentation. We are really grateful to you for the development of device therapy and heart failure management in the country. You also done a lot for spreading the heart rhythm activities in our country. So there is a question, as there is, the ARNI, the use is increased over the last few years. And there is said that due to use of ARNI, the implantation of device management is a bit delayed. So is there is chance of increased arrhythmic death due to delayed in device therapy in heart failure?
So the question is that, you see, if you look at historically, we were waiting 9 months before implanting device. So I think no question about it, that maximization of treatment. And if you look at the what we do here, that we have live vest, which have external device. But if you take a non-ischemic cardiomyopathy versus ischemic cardiomyopathy, you can use other risk stratification methodology to find out who is at high risk. But I think the delaying therapy, and if you look at the mortality in the first year, that when you have the device implanted, first year, there is no difference between medical treatment versus ICD. So no question about it. These newer drugs, especially this combination of neprilysin and sacubitril is a wonderful drug, and they should be maximized. I cannot overemphasize the importance of this medical treatment.
Thank you.
Thank you.
There's a question for Manohar sir. Sir, do you hear me, sir? Manohar sir? Yes. Sir, among the sodium glucose co-transporter, which one you think superior and why? There's a question from the audience.
There is no head-to-head trial actually. So right now this is very difficult to say.
So what is your current practice pattern regarding this?
Just empagliflozin and dapagliflozin are the more widely available SGLT2 inhibitors, and empagliflozin is probably being used more.